Leo, I'm going to transition to kind of the next paradigm that's on the horizon, and that's the kind of IO-IO combinations. We saw some data at between AACR and ASCO looking at Checkmate 227 and kind of our favorite anti-PD-1, anti-CTLA approach, in this case nivolumab, ipilimumab. What are your thoughts on Checkmate 227 and where we are? And of course, this also piqued everyone's interest based on a second biomarker beyond PD-L1, which is tumor mutation burden. So your summary and thoughts on that?
So we saw from 227 and also Checkmate 568, which was the single-arm study with nivolumab and ipilimumab, that PD-L1 and TMB are not necessarily co-expressed. So you can be PD-L1 high and TMB low, but you can be PD-L1 low and TMB high. So one doesn't substitute
and
for the other.
They don't correlate at all.
Correct, yeah. So the Checkmate 227 is a huge trial. It's 2,000 patients. And the biggest problem is we're seeing little bits of data at a time. So we're seeing data on 200 patients, and then we see data on 300 patients. And I think we could make more sense of the study if we saw the entire trial. What I like about this study is that it's the only trial that has, many of the studies we've seen are chemo plus or minus IO, and there's no IO alone arm. And so 227 does have that third arm, which will help us maybe figure out who should never get chemo and can do well with IO alone. We've seen at World Lung, and we saw at ASCO and AACR, that TMB did predict response with Nivo-Ipi, and patients with high TMB had an improved progression-free survival with Nivo-Ipi, and even with Nivo compared to chemotherapy. We've had a press release that we haven't seen that has translated into an OS benefit in the patients with high TMB. And again, they're using the cutoff of greater than 10, so that we're also got to keep in mind which cutoff we're looking at with the different trials. So once we see the OS data, we may determine that is an option. And so maybe if you've got a patient who's PD-L1 less than 50%, you can send TMB and determine maybe they don't get Pembro single agent, but they get Nivo-Ipi. I think it's going to become more and more confusing. The biggest issue is, who do you test with? Like, you can't do your local panel. Where do you send it for? And if you're sending it out, is it good enough to wait a month to start those patients on therapy? I think that's going to be the biggest challenge once this data is available and if these agents get approval.
Thoughts over here, Tom?
So I had a lot of enthusiasm after AACR, and those progression-free survival curves separated out right nicely. The press release is hard to interpret just with a couple sentences, but I was expecting it to be a positive trial. You sort of handicapped. I think we really need to see the full data set, because like Leora said, we've seen bits and pieces of this, and I have trouble keeping which iteration we're talking about, you know,
and I think it's fair to say that, I don't remember the exact number, but it was only a minority of patients that actually had TMB analyzed that were available for TMB. So it's a subset of that.
Yeah, I think like 45 or 50% were TMB evaluable. Of those, about half were high. And so, you know, and then when you sort of try and counterbalance for prognostic factors, it's hard to interpret.
Yeah. Max?
So I think for Checkmate 227, I think the strongest in this trial is TMB positive, PD-L1 negative, show a really long duration of response. And I think those patients will get these two IO combinations. In our country, we get TMB just from Foundation One. We don't have an own test, and we have to implement that in our pathological report. In the moment we don't have it, as soon as we have the FDA approval or EMA approval, I think we will start to test TMB locally also. But this is it's a challenge.
I mean, I think there are lots of issues around how do you really measure TMB, and to your point, what's the appropriate cutoff? Is it different for monotherapy versus is it different for IO combinations or with chemotherapy and those sorts of things? The other issue is, and we'll see data at this meeting, plasma-based TMB, is that an option in patients? You know, we've gotten so used to molecular testing based on blood and plasma that it's tempting to be hopeful about a plasma-based TMB approach, which would be helpful.
Yeah.
Yeah, in many ways, I agree with your initial comments about Checkmate 227. It kind of follows the paradigm. If you can't convince them, confuse them, right? And so it's been kind of a you know, as you say, bits and pieces and different subsets and the PDL1 negative and stuff like this. So it's really hard to you know, with a study, as you pointed out, with 2,000 patients that we thought we were going to get some clear messages from. I think we're not getting a clear message from this. So. You know, it's hard to know in routine clinical practice. Is this something, say, a community oncologist in Tennessee should be sending out and waiting for a TMB at this point, or do you think it's too early?
So I think it's too early.
Yeah.
And I think we have to sort out the TMB, how you're testing. Interestingly, we've actually started seeing more patients who are getting tested have some sort of TMB platform on their testing, be it Foundation or Caris or wherever they're getting their testing done. But you know, at centers like our center, we do our own in-house panel. We don't have TMB there.
Right.
And then is there even enough tissue to send out for TMB, and who's going to pay for 2 different panels? So I think it's early to adopt that regimen outright.
You agree?
Yeah, we have one of the trials, and logistically, you really have to plan ahead. And you know, the times I've put people on trials, it's people with brain mets where they're getting the radiation to the brain. I can send it out. I have the luxury of 3 or 4, or they need radiation to a painful bone met or something like that. But logistically, there's going to be a lot of challenges as we try to implement it if this trial's positive. And I think we'd like to see harmonization too across the platforms to make sure high TMB is really high TMB, I think.
Yeah, and when we have a blueprint-like project like we had for PDL1, we have that ongoing in ISLAC right now. So we'll get some clarity on what's the best platform for tumor mutation burden analysis and that sort of thing. So again, I take from the comments here that IO-IO combinations are exciting, but maybe not quite ready for prime time. The TMB is a little early for routine clinical practice. So, you know, essentially, as I look at this the past 6 months, what we've essentially done is take kind of traditional first-line chemotherapy that we've used in non-driver populations, and prior to 6 months ago, we would use immunotherapy second line, and what we've done is kind of taken first line and second line and kind of put them together in these complicated chemo IO regimens, and we talked a little bit about what the optimal strategy is based on histology